Buongiorno tutti. Because I cannot speak in Italian, I will now speak in American English with an accent. I come from California, at Stanford University School of Medicine, and my work involves the area of looking after newborn babies and protecting them from any illnesses or injury. And I've been doing it for some time. Very recently, actually last year, we created a consortium called CURhE, which is the global initiative to eliminate hemolytic diseases. It's actually focused on the elimination of universal Rh disease elimination. And as I speak to you and thank Madam Chairman and Mr. Chairman, as well as the rising students and scholars who are sitting in the back, this area may seem very new to you. And so let me first ask you a question. For those of you who are less than 30 years of age, raise your hands. Thank you. How many of you know your blood type? Just less than 2%. All right? That is what I'm going to be talking about. All right, good. It is very nice to be here in Venice, because in Venice we learned that it's important to stand on the shoulder of our ancestors. And through that, we have learned precision healthcare, and we are now on the journey to actually transfer the knowledge that we have, to take the evidence of our treatments and cures and convert them into a systems approach. This is the basis of Obamacare that you heard this morning. How we do that is through a transformation of knowledge in healthcare by having it have the same safety standards as aviation safety. Just as you sit in a plane, you hope that the plane will not crash. Similarly, you hope that if you have a health experience, that you will not crash. And it is in this area Stanford has assembled and pioneered a team of transdisciplinary scientists, not interdisciplinary, not multidisciplinary, but going across the various disciplines so that we learn to speak the same language, so that ultimately our families and our patients may understand the conversation we are having about them. So I also speak to you on behalf of the minority that is there, and there's no minority here in this audience, and that is a minority of the newborn baby. Luckily, as they grow, they become majority, and we hope that those of you who are young and less than 30, as you become future leaders, that you will remember the newborn child and their healthcare, as well as make healthcare policies towards their well-being. So we all know a healthy child, and we all wish to have a healthy child. It does not matter whether you live in Venice, or in Palo Alto, or in London, or in a village in India, or a village in Uganda. Next to that is a baby whose blood was damaged during the process of pregnancy and birthing. And with that damage in that blood, that healthy child, there was nothing wrong with that baby's blood, but it was the exposure of that baby's blood to antibodies that came to the baby through the placenta that damaged the baby to get brain damage. So this is a child, Krista, who is trapped in a wheelchair. She cannot move her body or her muscles because she cannot control the movements of those muscles. Those muscles go into painful spasms, and she is unable to hear. But as you can see from her smile, she is a very intelligent child. In fact, she's very good at mathematics. So how did this healthy baby inside a mother's womb get to be brain damaged soon after birth? This is a condition that in the US, a group of mothers were able to lobby various leaders in the healthcare system to declare as a never event that it should not happen in modern day medicine. If it happens, it is the same if you go to an operating room and instead of having your left arm amputated, you get your right arm amputated. That is how serious this condition is considered. In fact, CDC has declared that one child with this kind of brain damage, which we call as connectress, is one child too many, because almost all of them are preventable. So the story begins with the fact that we all have red blood cells in our body. They are nice, healthy, and they're shaped like donuts. And they float around in plasma. And a healthy fetus will have healthy red blood cells. But when exposed to hemolysis, that is, antibodies that have come across the mother's placenta, they break down those red blood cells, destroy them, so the amount of the red blood cells go down, and that is called anemia. And as the red cells break down, we trigger a reaction in the body, which is called the heme catabolic pathway, whereas the heme component of the hemoglobin, which is present in the red blood cells, gets converted into a waste product called bilirubin and a gas called carbon monoxide, which acts as a neurotransmitter. This reaction takes place under a very common enzyme which is part of our body called heme oxygenase. This reaction provides us three pieces of information that are vital. One is the formation of bilirubin, which at a high level can be damaging to a developing brain. That it forms carbon monoxide that we breathe out and we can measure as a measure of production of the bilirubin that is making, because it's an equimolar relationship. So I can measure the carbon monoxide made by a baby during normal breathing and know if the baby has hemolysis or not. And then I have the heme oxygenase, which has the potential that we can inhibit it with a drug and therefore bypass the system. But those drugs are still very experimental, and they have not yet reached the market and may take another 10 to 15 years. In the meantime, what we have done is develop an alternate approach that I will speak to you about. And that is what this baby did not get. This is a baby with acute connectress. You see the spasm of the back muscles and the tone. You can see the pain that this baby is experiencing. And this is an Iraqi newborn baby born in Baghdad at the height of the war that occurred a few years ago. So in the green zone area, this mother and mothers like this other woman were unable to get to the hospital before delivery to get interventions to prevent RH disease. And in fact, we have reported that the rate of connectors went up 1,000-fold. These were silent deaths that occurred that were not recorded in the war damages that took place. And it is these kinds of babies that we worry about in the rest of the world. Because we know that the loss of a healthy child, because this child is otherwise healthy, is a supreme tragedy for any society. It doesn't matter where in the world that society is. And we think and we believe that newborn health should not be bordered by geography or history, but sustained by biology, and that is what you have heard this morning. So, For our talk, I will focus on the most common problem that we actually solved almost 60 years ago, and that is rhesus blood group incompatibility. Now, what is rhesus blood group incompatibility? It has nothing to do with monkeys and chimpanzees. It just happens to be a name given to the Rh factor, which is an inherited protein on the surface of red blood cells. If you do not have this protein on the surface of your blood, you are Rh negative. Is anybody here who knows if they're Rh negative? Okay, about 15% of you are Rh negative, and you should know that. Now, an Rh negative person who is exposed to Rh positive protein, this is a person who becomes sensitized and produces antibodies. This happens when an Rh negative woman is pregnant and her fetus happens to be Rh positive, where the father's blood type has gone to the baby. In the 1950s, every year in the US, about 20,000 babies either died or had severe brain damage annually from this condition. And the mechanism is fairly simple, that here you have a baby inside the womb who's Rh positive, the mother is Rh negative. On the surface of the red blood cells, we have blood type A and B that were actually described in 1900s, and Landsteiner got a Nobel Prize for that. And then there was a description of Rh back in the early 50s, and that was described by Philip Levine and independently by Alexander Wiener. And the thought process is that during the first pregnancy, an Rh positive baby will sensitize the mother. The mother will make antibodies, and these are good antibodies, because that's how nature works. When exposed to protein, will make antibodies to protect itself. With the second pregnancy, if the baby happens to be Rh positive again, that baby will trigger the same response, except now it is an exaggerated response. And as the pregnancy progresses, those antibodies go across and hurt the baby. And they will cause anemia before the baby is born, and they will cause an elevated bilirubin level before and after the baby is born. So that before birth, there's a likelihood of stillbirth, multiple fetal losses due to the anemia. During the first week, there's increased bilirubin production and high levels of this neurotoxic bilirubin. And then these babies get jaundice, and we can treat them with special blue light. And just to go off on a tangent, this is something that we learned from our nursing colleagues who would take babies out in the sunlight. And we have learned to harness the blue color in the sunlight to actually treat babies with this light to lower their level of jaundice. Once brain damage starts to occur, there's very little we can do. So the focus has to be purely on prevention. If we do not treat these babies in time, they will get a hearing loss. It's one of the most common causes of deafness. We'll get the brain damage. Or in babies who are mildly affected, it may cause subtle signs like being awkward and clumsy and so on. So, going back on the ancestors of the shoulders of our ancestors, in 1950s, this was a huge problem. And we tried many different technologies to try and help that pregnancy. And they were novel and they were new for their time. But it was only in 1967 when RHD antibody was able to be manufactured, and was actually manufactured in Buffalo, New York, that this drug was actually created, and many different forms of these drugs were made available, that you see a sudden decrease in the number of babies that were dying every year in the US. And this practice has been implemented as a guideline for every pregnancy in the US, in Europe, and in and in Canada. So that was good news. And so that in 1980s, while I was in early stages of my medical school career, we would hardly see a child with Rh incompatibility. So why are we talking about it today in 2015? Well, I was interested in this area because of the brain damage, and I am an expert in systems approaches to medicine. So I wanted to see if the system approach was working in the rest of the world. And we estimated the burden, the global burden, country by country, of Rh disease and high levels of jaundice and the brain damage. And as I looked at the data just a couple of years ago, which is why this became a crusade for me, is this particular picture, and I'd like you to focus on the red bars. Red bars are the children with Rh disease who got brain damage. If you look at it, it was lowest in the countries, but not completely eliminated in high-income countries. It was present in Southeast Asia to a substantial degree. But the highest rate was in Eastern Europe. Surprise, surprise. It was also present in South Asia, as well as in sub-Saharan Africa. In fact, the numbers of Africa and South Asia are much higher because the birth rates are higher in those countries. But when you adjust to the birth rate, it is a huge problem in our own backyard here in East Europe. So we identified that about 24 million babies a year could be having hemolysis. That of those, 500,000 of those babies every year can get severe jaundice or Rh disease in the rest of the world. That puts 1/4 of them at risk for death, 11% at risk for stillbirth, and 13%, or about 75,000 babies a year, with multiple neurological disabilities, things that we in the West consider as a never event. And that is a tragedy. The answer is nothing new, but it is making systems-based. It is making sure that if you're flying a plane in sub-Saharan Africa, that is not likely to crash, just as not likely to crash in Europe. So the women and children who have the least voice and are the most vulnerable, who did not have any impact on these policies, get ignored. And we'll talk about that perhaps in questions and answers. But when we track them prenatally, when they become pregnant, or soon after the birth, or in combination, we can apply prevention with this anti-D immunoglobulin. But for that, we need to know the mother's blood type. We need to screen her for antibodies if we think she is Rh negative. And then once the baby is born, we need to screen that baby for hemolysis. So if you wanted to know your blood type, you probably went to a hospital laboratory. Somebody stuck a needle in your vein, took a sample of blood, and said, "Come back tomorrow, and we'll give you the results." Well, you can't do that in a village. You can't do that in a rural area where most of the babies are stillborn. So experts have gotten together in various countries, and they feel and have proposed that we need to galvanize the younger medical community that has not seen this disease, so that we can launch some programs with societal partnerships where we empower the mothers and let them know what it means to have their blood type. We want to use affordable technology so they don't have to go to the hospitals, but they can get their blood groups and tests done in the privacy of their own home. And we want to facilitate an evidence-based global standard of care, just as we are doing with the beginnings of Obamacare. So our message is simple: no RH, right? We are of the opinion that through a social media initiative, knowing RH will lead to a globally endorsed universal curriculum, that will identify both societal and provider champions who can help teach and coach mothers who are Rh negative. And we can implement an accountable program that is patient-centered using the guidelines of healthcare for patient safety from the Institute of Medicine. And this has been done before in other areas. So we think our message is that every person, man or woman, boy or girl, every person knows their blood type. You'll remember it. It'll be important for you in an emergency. It'll be important for you if you or your spouse or your girlfriend becomes pregnant. It'll be important to you if the woman has to go through a miscarriage and needs to be reminded, because that's when she can get sensitized. So our mandate for CURhE is to promote that all parents and pregnant women should know their blood type, and to ensure with that an unfettered access to Rh immune prophylaxis. It's not a very expensive drug. When you put it across the system to the community, it actually comes down to a few cents on the dollar. And that women who are negative, Rh negative, that there be a grassroots-led global campaign. We want to be able to create and action this through a multimedia system so that we can actually launch a global campaign. In the same state, when we were dealing with Rh disease, we dealt with polio, and we have eradicated polio. So surely we think we can eradicate and eliminate Rh disease. So to get a sense of what the world was doing, at Stanford we were very lucky to have some bright students like yourselves come and work with us over the summer. And this summer, 2 students came to work with us, one from China and one from India, and they reviewed the literature for us, and this is a brief report that I will go through somewhat rapidly. We did a review analysis of what is the body of literature that says that this form of intervention works. What I was surprised to see that the first dose ranged from 28 to 34 weeks. There was a variation there. That most countries would recommend treatment for a newborn baby within 72 hours, but the range could be as much as 10 to 28 days. That the number of doses varied from 2 or 3, and the actual dosage also varied. So the charge to the students was, look at every country, go on the web, and go through a search to see what information is there in the public domain, where countries have highlighted what their national policy is. Because ultimately, if they believe it, we hope they will practice it. And so we said, are there national guidelines? And so we searched. And what we found was only the colored areas had national policies. But there's vast areas of the globe which did not have a national policy. That if you looked at Europe, you saw that in Britain, Ireland, and Greece. And you see the variations in the dosages and the timing of the dosages. France, Switzerland, and Czech Republic were the other 3 nations. Again, a variation. In the North America, USA, Canada, Mexico, and Quebec, Quebec had to have its own set of guidelines. You see a great deal of variation as well. In Middle East, Afghanistan, and Israel had policies, but again, a wider variation. Sub-Saharan Africa, 3 countries, 3 of the larger countries, a lot of variation. Asia, India, Japan, China, Singapore, Sri Lanka, you see a wide degree of variation. In Australia and New Zealand, even though they're close to each other, you see a variation in practice. In Latin America, in Brazil and Chile, you see some variation in practice, not much. So what we noticed that there were 24 national guidelines out of the 184 different countries that were available online and in the public domain. And we're talking about open access over here. There was limited uniformity in the timing of drug administration, number of doses, and dosages. But 3 countries had the most influence on those guidelines. They were UK, Canada, and USA, and there was differences between the 3. So obviously, we have to establish a consensus as to what should be the right approach. We need to bring these experts onto the table and need to have a common language, transdisciplinary approach. What was important as we looked at the variation, that there was a loss of evidence in medicine data in translation, but you went from one country to another. Public health experts, who themselves may not be doctors, were adjusting dosages because of a matter of convenience or cost, or because they realized they had a more difficult population to access. So in that way, they were perpetuating a discrimination. And this is not an evidence-based approach, and so it calls for us to make that translation very uniform. Question then is also scalability. What we have learned in North America and in Western Europe, can we scale this up to the other countries? And should we be making modifications? So are the local guidelines scalable to a national level? This is the work we have to do, and is our mission for the next 3 years. There are inter- and intra-country challenges because many countries have a fractured healthcare system. There are local fiscal priorities that they have to deal with. There are bottlenecks in timely patient access, and there are impediments for families to navigate the health infrastructure. This is where we think the social media can help make a difference with the help of a coach who is local and is a peer. And this is the work that we also have to do over the next 3 years. We investigated with the Clinton Foundation as to the cost of this intervention, and they felt that the cost of the drug, the way it is being used at the moment, was very cost effective. So we don't have to look for cheaper drugs. We just have to make sure the best drugs that are available and are proven actually reach each individual patient, and that each individual patient who is at risk knows to ask for them. And I can share with you very many stories where such access has been denied. In Eastern Europe, the top 10 nations in a ranking order that have the highest burden are Russian Federation, Ukraine, Uzbekistan, Kazakhstan, Romania, and so on. So tomorrow I go and meet with the Romanian delegation to see what we can do at the national level to understand what is the cause of the problem in that nation. Our approach is simple, that at the moment there's a current ad hoc approach. We screen the blood for the blood test in a laboratory. There is no WHO policy that requires that every mother know her blood type. So we need to change that. Prevention is inconsistent because national policies vary. And that is something that is important, and especially in countries where the termination of pregnancy or a natural miscarriage happens and is not discussed, and the mother does not know of the need to go and get herself protected from the sensitization. And so this area is often overlooked. What we propose is a simpler strategy. That is a point-of-care testing, and there are such tests available. There's one called the Eldon card, where you can actually do this evaluation in the privacy of your home, and has actually been used and tested by the US Army for their soldiers in emergency. So it's well proven, and that's something that can be easily made available to communities. And what we need are high school students and graduate students who can go out and champion in the field of global health to help train these communities to get their blood types done. And in a prevention strategy, we want to get a national and a global consensus so that we standardize the care, we have the evidence, we need to develop some more evidence if we need to, and make this thing work. And making it work is the key. So with this in mind, The take-home message for the group here is that CURhE believes that a global campaign will inform prospective parents of the rhesus factor worldwide, such that a preventable, life-threatening disease in the newborn and possibly in the mother is eliminated. Know your blood type, and that is my message. Our friends and colleagues over here are listed by their seals of their universities, and we have partners with Eldon Card and Kedrion and other agencies, as well as several universities, and this is a growing list. I also like to thank my students who came as volunteers in their high school years and worked with us under the supervision of a medical student, an undergraduate student in college, and my research assistant to help generate the data that I shared with you. Thank you very much.